All right, I was asked to talk about small fiber neuropathy today and to associate this with autonomic testing. So I'm going to be starting with a case. It's not a very typical case, and by far not one of the most common that we see, but I chose to start with an uncommon case for the fun of it. So it's 60 years old, right-handed Caucasian male, with 2-year history of cardiomyopathy of unknown cause, recently lost 25 pounds in an unexplained way, and in the past 15 to 18 months, started feeling the ball of his feet swollen and occasional pain of his knees, elbows, and shoulders, dry eyes, dry mouth, and recent total impotence. And this is why I saw him, for the impotence. I'm not a urologist, but you know, autonomic physicians see symptoms related to almost every organ system. He denied urinary problems, sweating problems, or swallowing problems. He even denied dizziness, which is the most common thing that we see. And it is only upon further questioning, and really I had to ask him specifically this question, that he admitted to some mild burning of his feet that is worse at night than during the day. When I examined him, his neurological examination was essentially normal, except for, during the vitals in the clinic, a borderline orthostatic hypotension, a drop of exactly 20 millimeters of mercury systolic, and no tachycardia in response to that. So further testing confirmed the diagnosis of a non-length dependent small fiber neuropathy. So what would we do in such a situation? I think most of you would, because of the symptoms in the feet, order an EMG. Would you agree? Yeah. But autonomic testing is here to help, and this is what I'm going to expand on. Now, the blood work, we also probably, most of us are going to ask for some basic blood work. And there are other tests that we can talk about a little bit later that are useful and helpful. So the EMG of this gentleman was normal. We would have stopped here, and without other diagnosis, wasn't it for the autonomic tests? So we did a series of autonomic tests, including the QSART, the Quantitative Pseudomotor Axon Reflex test, which showed a mildly reduced sweat output at the forearm, proximal leg, and calf, but not at the foot. So a reverse pattern. Generally, it's the reverse that we see. We did a heart rate variability to deep breathing. This was a little bit low. We did a Valsalva ratio during a Valsalva maneuver, which was abnormal. And we tilted this gentleman, and we saw a moderately severe orthostatic hypotension, confirming the findings at the clinic. So what does autonomic testing add? First of all, it establishes the presence or absence of autonomic fiber involvement. And you can say, okay, if the autonomic testing is abnormal, and I can tell you those are very sensitive tests, then there is involvement of the autonomic nervous system. It excludes also CNS etiology when abnormal. One of the differential diagnosis or questions that this man had when he came to see me is, does he have MS? So they did an MRI of his brain before he was sent to me. It was abnormal, just a few didsels here and there. They never knew whether he had MS or not. Obviously, he doesn't. Define a prognosis. So disease-based dysautonomias, like with multiple system atrophy or diabetes, are more serious than syndromic, like POTS, for example. So this is where autonomic testing can help us. Autonomic neuropathy in diabetes is a very serious condition. So if I want to try to summarize what autonomic testing helps us with, I can say that it answers 4 questions. First of all, it localizes the lesion in the neuroaxis, peripheral nervous system versus central nervous system. And this is thanks to 2 tests of sweating, which are the QSART and the TST, thermoregulatory sweat test. Second, it identifies which branches are affected. The pseudomotor, meaning the branches that produce sweat, vagal, parasympathetic, cardiac, vasomotor, sympathetic, and this is thanks to 3 cardiovascular tests, which are the heart rate variability to deep breathing, the Valsalva maneuver, and the tilt table test. And when you combine all these tests, you could come up with a differential diagnosis, and it can help your workup. And then also, when you come up with a diagnosis of syncope or orthostatic hypotension, like in this case, the tilt-induced changes related to the timing of the symptoms can direct us in a certain direction versus the other. So let's talk a little bit about those tests. The first, I mentioned it twice already. This is the Axon reflex test that was described by Philip Lowe at Mayo Clinic in 1983. So this is a test that tests the postganglionic segment only. So you know that the autonomic nervous system relays on a pre-ganglionic segment, a post-ganglionic segment, and in the middle you have the autonomic ganglia where the synapses happen. So this is a peripheral autonomic problem. Basically, what we do is we put some capsules, like the ones you're seeing here. You're not seeing it. Now you're seeing it. On the skin in 4 different sites, which are standardized. Those capsules are filled with acetylcholine. You know that sweat response is cholinergic, sympathetic cholinergic, right? And we drive acetylcholine through the skin through iontophoresis with an electric current. And this capsule has 2 concentric chambers, one which is the larger chamber filled with acetylcholine. This is where the iontophoresis is going to come from, all right? And then the sweat response that will happen there will be collected in the inner chamber. And there is a hygrometer, so basically a measurement of the humidity before the sweat happens, meaning outside of the capsules, and when the air goes through the capsule. And this difference in hygrometry gives us an estimate of how much sweat has been produced in liters. So very small amounts, obviously. And this test, obviously post-ganglionic fibers, looks at the sweat small fibers. All right, so we have 2 types of small fibers, the C fibers. You have the somatic small fibers that test or mediate pain and temperature. We're all familiar with that. But we have also the autonomic C fibers, very thin nerves. I'll show you a picture of them. And this is what we're testing here. All right. The thermoregulatory sweat test, this is the second sweat test that we use. So basically, this is I call it a sophisticated sauna, where the patient is covered with a powder. We call it alizarin orange, cornstarch. And we slide the patient in that sauna. We heat the temperature up. We wait until there's an increase of 2 degrees Celsius in core temperature. And then this, because of the sweat production, the orange becomes purple, and we slide the patient out of the box, and we start calling in photographers to come and take pictures of this man, the purple man, and then we will see what areas have sweat, what areas have not sweat. And there are certain patterns that have been described by Robert Feely when he described this test, and this is a normal pattern on the left-hand side. Another one shows you a radicular pattern, so basically the defect is in a radicular pattern. A peripheral pattern. You see in the third sketch that defect is from the elbows down and in the lower extremities. This is a peripheral pattern sparing the core. And then in a central nervous system problem, the extremities are spared, but the center of the body is affected. When we combine both tests, we are able to tell if the lesion is peripheral or central. Let's move on to the cardiac response to deep breathing. So we always do that. Maybe we are not aware of it, so I'm going to demonstrate that. I'm going to ask everybody with your right hand to put your second and third digits here on the pulse of your left hand. Take a few seconds to locate it well. And we're going, once we have located it, to take a deep breath in, and out, 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 out. So while we're doing this, we're going to pay attention to our heart rhythm. So once again, deep breath, in, 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 out, 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 out. If you're normal people, you should see a variation in the pulse frequency. So basically, when we inspire, heart rate goes slightly up. When we exhale, heart rate goes slightly down. Have you experienced that? If not, find me outside at the end. This is heart rate variability. This is an essential function and is mediated by the vagal nerve. So if this variability is absent, we know that there is a vagal problem. The cardiac response to the Valsalva maneuver. We all do that if we've ever been to the bathroom in our lives. So basically, we are blowing against a resistance. And if we do this, this is what happens. We're blowing against a resistance. So we're increasing our intrathoracic pressure. By doing that, venous return is slowing down because of the pressure. Venous return goes down, meaning stroke output goes down. Stroke output goes down means blood pressure goes down. Blood pressure goes down, our baroreceptor senses that and tells our system to activate our sympathetic nervous system. The peripheral vascular adrenergic system will constrict, and this will prevent further drop in blood pressure. So that drop will stabilize itself. And now we release. Once we have released, stroke output becomes normal, but we're pumping normal blood volume now against a peripheral area, constricted peripheral vasculature, which means that the blood pressure is going to shoot up. Okay, and these are the four phases of the Valsalva maneuver. So let's look a little bit more in detail at this. So we're blowing in. This is a mechanical thing where blood pressure goes up just because of the increased pressure that we have done. Then, because of the decreased venous return, blood pressure is going to start dropping down. And because of the peripheral vascular constriction, to counteract this, blood pressure is going to stabilize itself and even rebound a little bit. And here's where we let go the pressure. Mechanically, blood pressure is going to drop down because of the sudden let go. And that's the last phase, phase 4, where the heart is pumping against a constricted vasculature and we have an overshoot of blood pressure. When this happens, there is a reflexic cardiac change also that happens. So basically, during that drop, which we call early phase 2, heart rate to compensate is going to try to go up. And during the overshoot, heart rate to compensate is going to go down. This is a reflexive cardiac response to the blood pressure changes. And when we measure the ratio of the highest heart rate obtained to the lowest heart rate obtained, we have what we call a Valsalva ratio. Okay? So the Valsalva ratio could vary because there is a problem with heart rate response. And often if the blood pressures are intact, this reflects a cardiac parasympathetic problem. But if the blood pressure is the reason why the heart rate is not changing, then the problem is not anymore a cardiovagal problem, but it is a problem with the peripheral vasomotor adrenergic system, meaning a sympathetic problem at the peripheral vasculature. So that's why it's very tricky, and we have to interpret the Valsalva maneuver results very cautiously. And this is the last cardiovascular test that we do, which is maybe the most common. Cardiologists do that all the time. And this is the tilt table test. So basically, we're measuring a baseline blood pressure and a baseline heart rate, and then we tilt the table at 70 degrees up. Some people do it 90, some people do it 60. I don't think it matters that much. And then we see what responses happen here. So blood pressure drops, or heart rate goes up, or everything remains steady until the last minute and something, all of a sudden, everything drops down. And these are the three orthostatic symptoms that I'm putting on this slide. So let's talk about the first one, the orthostatic hypotension, which is defined as a gradual, sustained decrease in systolic blood pressure of more than 20 millimeters of mercury, or diastolic blood pressure of more than 10 millimeters of mercury. So you see this pattern in blue. So it's a gradual drop in blood pressure. Normally, heart rate should compensate, and it should go up. If heart rate does not compensate, this means that there is also a cardiac sympathetic problem, and we call this neurogenic orthostatic hypotension. And generally, this condition is caused by an arterial denervation, and it impacts mainly diastole. And the cardiovascular reflexes, like, for example, heart rate variability to deep breathing, often are normal. I mean, sometimes they could be abnormal if the dysautonomia is affecting all kinds of, or all aspects of the autonomic nervous system. And as I said earlier, the prognosis is generally more guarded in these conditions, and it's a disease-based process rather than a syndromic-based process. So this is not POTS, orthostatic hypotension. And when we look at the small fibers, we see that they are diffusely and severely affected in most cases. But also the large fibers could be affected as well. I'll be talking about that in a second. The postural tachycardia syndrome, we've heard that from Dr. Raj earlier. I'm not going to spend too much time, but quickly, it's a definition of heart rate increase of more than 30 beats per minute in the first 10 minutes, hopefully first 3 minutes, with no major change in blood pressure. So this is what you see. Blood pressure is steady in blue, but this is the heart rate that goes up. Okay, and this is a syndrome, POTS, and generally small fiber could be affected, but not as severely and diffusely, and sometimes they are only affected focally in this condition. And then the reflex syncope, which we call vasovagal syncope, cardioneurogenic syncope. There's a sudden drop in blood pressure and heart rate at one point during the tilt. Both drop. And generally, there's no small fiber involvement here unless vasovagal syncope happens as a reaction to a hyperadrenergic response. Okay, sometimes we see a POTS pattern, and then suddenly, puff, here is the vasovagal syncope. And this is often the reason why POTS patients faint, in my experience. All right, so pupilometry, this is a test that is less widely used, but I think it's very sensitive because we're testing very short nerves, okay? The nerves that go from the midbrain basically to the eye. A very short distance. They are affected earlier than the larger or the longer nerves, like the vagal nerve, for example. And when we look at the pupilometric response, which basically is the light reflex, which we all do in our clinics, right? But here it's computerized. We can dissect it into its different components, the first component being the constriction of the pupil, heavily under parasympathetic influence. At one point, that stops the constriction. This is where the parasympathetic has slowed down because the sympathetic has taken over, and then suddenly there is a withdrawal of parasympathetic tone. The pupil is left under the sympathetic tone uniquely, and this is what causes the redilation of the pupil. And you have two phases of redilation. The initial phase is the rapid redilation, and then progressively parasympathetic tone comes back and kicks in. This slows down the redilation, and we can measure the velocity of constriction, the amplitude of constriction, the redilation velocity, and we can measure the time it takes for the pupil to go back to 75% of its original diameter. This is a sympathetic measurement. Very useful test, neat test, quick test, 3 seconds in the clinic, but you have to also be careful how to interpret it, because the pupil is under the influence of so many things, okay, including intrinsic eye problems, so you have to rule all these out. So it becomes sometimes very complex to do it. And then a skin biopsy. So we're talking about small fibers here. The skin biopsy is the fact of taking punch biopsies at mostly 3 different sites. Sometimes, most often we go distal leg, distal thigh, proximal thigh. These are 3 millimeter specimens that we send to specialized labs. And I'm showing you here an example of this case. Basically, what you see is the epidermis, which is right here, and the dermis below it. And normally on the right-hand side of that slide, you should see sweat glands in the dermis. You see they're like round baskets, and you have those dark stained fibers around them. This is normal. And then, if you look at the epidermis, you see those fibers that cross from the dermis up, and they're stained also in black, and we can count them. There are normative data that tell us if those are normal or not. If you look at the left-hand side, you see that all this is denervated. We don't see those fibers anymore. So this tells you that there is a total denervation of small fibers. I was given this slide by William Kennedy at the University of Minnesota, who had very nice staining protocols to look at those nerves. And you see here the epidermis in blue, the dermis beneath it. You see those fibers stained, immunostained in green fluorescent green that cross into the epidermis, like here. And we count those fibers. The problem is that this technique fades out very quickly compared to the previous technique, which was developed at Johns Hopkins. And that's why we prefer the other one, because if we want to go back to those slides, we can still have them intact almost. So we looked at the sensitivity of QSART versus skin biopsy, because both are, 2 minutes left. All right. So both are tests to check for the small fibers. Obviously, the skin biopsy looks at the somatic fibers that cross into the epidermis mostly. Recently, we are able now to count those around the small, the sweat glands. That's very helpful. But the QSART typically looks at the autonomic small fibers, the sweat small fibers. And obviously 2 different types of population, even though these are the same, anatomically they're the same types of nerves, but we're not testing the same population. So they don't correlate well, the 2 tests, but we found that each one of them has a sensitivity of about 50% only. When you combine them, you can go up to about 73, 75%. That's why I recommend that we do both. All right, so to wrap up, this is the case diagnosis. This man had a fat pad biopsy. We know that he had an autonomic problem. We know that he had a small fiber problem. And it's the fat pad biopsy that showed that he stained positive to Congo red, and so he had amyloidosis. So this is an uncommon presentation, but amyloidosis is a cause of small fiber neuropathy. And before I conclude, I know I only have one minute left, I want to give you an example of a more common presentation of small fiber neuropathy. In this case, a 48-year-old woman who presents to you because of a burning sensation of her toes. And that started like a while ago. She has gained weight in the past year due to overeating and inactivity. And when you examine this patient, you see that there is a loss of pinprick and temperature in stockings distribution up to the ankles. Vibration may be mildly reduced at the toes. Joint position sense intact, motor exam intact, gait is intact. So you know that these are the small fibers that are affected versus the large fibers, like in this case. This is a person with type 2 diabetes presenting with numbness and pain of her feet, legs up to the knees, loss of balance. On the examination, you see that the vibration sense is notoriously absent, the joint position sense is absent, wide-based gait, absent reflexes, sways in all directions to the Romberg test. So this is a manifestation of the big nerves being affected because of diabetes. So based on which presentation you have, this opens up a slew of etiological blood tests, and this is where I think the next topic is going to be about, how to go more in depth into the core cause of all that, and not just treat symptoms of hypotension, syncope, pain for small fiber, etc. And this is Dr. Goodman, who's following me, who's going to be talking about that. Thank you so much for your attention.